Morning, everyone. This is a great pleasure to have such a wonderful presentation with you all, especially with the likes of Dr. Navneet, who is herself a periodontist. Now, my topic is Smile Symphony, which relates the periodontal artistry with the modern orthodontics. Since we all know orthodontics is a very time-consuming process, and everyone needs fast treatment, which is why we are here with the Vilcodontics. Now, Dr. Vilco brothers are the pioneer in this branch, and Vilcodontics is also known as periodontally accelerated osteogenic orthodontics, which is a methodical exploration which is aimed at refining orthodontic therapy. Basically, in today's world, adults along with children are interested in improving their aesthetics, driven by heightened awareness. And in this case, Vilcodontics plays a crucial role. It it is also helpful in preventing the periodontal injury, and it doesn't have pocket formation, which is the case with laser these days. It also avoids tooth devitalization and it shortens treatment time. Basically, it's all in all a win-win situation for everybody. Uh, Moving further on, we should have a look at the history. Now, the history for Vilcodontics dates back to 1800s with the likes of Dr. Elsie Bryan, Cole, Duker, and Wilco. In 1893, Dr. Elsie Bryan was the first one to facilitate tooth movement with the help of corticotomy. After him came Cole, who in 1959 first used corticotomy to facilitate tooth movement as a mean of rapid tooth movement. He basically disrupted the bone's cortical plate to expedite the orthodontic treatment by overcoming resistance to tooth movement. And he postulated this theory as bony block movement. Now, what did he do? Basically, he reflected a full thickness flap, which was used to expose buccal and lingual alveolar bone. Then he made some interdental cuts through the cortical bone and barely penetrated the medullary bone. After this, he did subapical horizontal cuts, connecting the interdental cuts and penetrating the full thickness of the alveolus. After him, in 1960s came Duker, who investigated the effect of corticotomy on tooth vitality and the marginal periodontium in beagle dogs. Basically, he wanted to know what effect does the corticotomy cause on the periodontium of humans. So he selected beagle dogs for the same study. His results supported the idea of preserving the marginal crest bone in relation to interdental cuts. The cuts were made at least 2 mm short of the alveolar crestal bone level so that the crestal bone was saved, and it was concluded that neither the pulp nor the periodontium was damaged following orthodontic tooth movement after corticotomy surgery. In 2001, Wilco et al. Introduced accelerated osteogenic orthodontics, which is our today's topic, which was later known as periodontally accelerated osteogenic orthodontics. What he did was he basically combined the corticotomy surgery with alveolar grafting, showcasing safety, predictability, reduced root resorption, and shortened treatment times. They also showed that rapid tooth movement resulted from a transient demineralization and remineralization process in the alveolar housing, aligning with the healing pattern of rapid acceleratory phenomena. Basically, they showed that the continuous bone turnover was the basic phenomena for the fast tooth movement. Now, let's move towards the surgical procedure. So, the surgical procedure involves 6 major Steps. The first one is flap designing. The second one is corticotomy. The third one is particulate grafting, followed by suturing, orthodontic force application, and patient management. Now, let's have a look at each one of them. So, the first one is flap designing. The flap design combines a full thickness flap in the coronal aspect with a split thickness dissection in apical portions. So in this video, you can appreciate that a full thickness flap uh, is being engaged with the coronal aspect, with the split thickness flap in the coronal aspect. The split thickness dissection offers flap mobility for minimal tension suturing, and the periosteal layer exposes alveolar bone, aiding in the identification of the critical neurovascular structures so that we don't harm them. Preservation of interdental gingival tissues is a crucial thing, because for successful aesthetic outcome, the papilla should be preserved. So, for example, if we are making the cuts in the central incisor region, we should not make the interdental cuts, because they would not be very good for the aesthetic purpose. If we need to go through the central incisor region, then we have to do the tunneling procedure. Now, after flap design, uh, now, flap design is followed by corticotomy. So basically, what is corticotomy? We make incisions in the cortical plate area of the bone. A vertical groove is placed in the interradicular space midway between the root prominence in the alveolar bone. This groove extends from a point 2 to 3 millimeter below the crust of the bone to a point 2 mm beyond the apices of the root. So we basically we uh, make the corticotomy cuts along the region of the root, passing 2 mm beyond the apices of the roots. Now, these vertical corticotomies are then connected with a circular shaped corticotomy. Uh, we should not extend the cuts near any neurovascular structures, and the bone should be of sufficient thickness. Solitary perforations can be made to facilitate more tooth movement. However, if the bone is less than 1 to 2 millimeter in thickness, these perforations are omitted to ensure no damage to the radicular surface. In this video, you can appreciate how a corticotomy is being done. Then it is followed by particulate grafting, so that our bone healing happens at a faster rate. Grafting is done in most areas that have undergone corticotomies. The volume of the graft material used is mainly dictated by the direction and amount of tooth movement predicted, the pre-treatment thickness of the alveolar bone, and the need for the labral support of the alveolar bone. And the most commonly used materials are bovine bone, autogenous bone, decalcified freeze bone dried graft, allograft, or a combination of each of them, or maybe one or two of them. And use of barrier membrane is not suggested, because it would then hamper our tooth movement. Now, the last one is closure technique before our patient. For closure technique, sutures are typically achieved with non-resorbable interrupted sutures, and the specific suture used is defined by the thickness of the tissue. The sutures should approximate the tissues at the midline, and they should be placed first to ensure the proper alignment of the papillae. The remaining interproximal sutures are placed next, followed by the closure of any vertical incisions. And no packing is required, and the sutures are left for 1 to 2 weeks. And if the healing has been performed quite well, then we can remove the sutures. In this video, we can see how the interdental papilla are being sutured. Now, this is followed by patient management, because the length of this procedure is a little bit long and it's a little bit of invasive procedure. Sedation of patient is suggested. Use of short-term steroids are given intravenously or orally for patient comfort and clinical healing. Though the steroids are not given for a very long time, because the pain management has been done properly during the surgical procedure itself, and long post-operative pain is not seen usually. Also, antibiotics and pain medications are administered at the clinician's preference. Long-term post-operative administration of NSAIDs is discouraged, because then they would hamper our regional acceleratory phenomena, which is proven theoretically. Also, the application of ice packs to the affected areas also suggests to decrease is also just suggested to decrease the severity of any possible post-operative swelling or edema. Now let's understand some of the biology underlying PAOO. So the main part of our Periodontally accelerated osteogenic orthodontics is regional acceleratory phenomena, also known as RAP. It is basically a localized osteoporosis state, which is a part of healing event and is responsible for the rapid tooth movement. It is initiated by injury to the bone, and there are two main features of regional acceleratory phenomena in bone healing, including decreased regional bone density and accelerated bone turnover, which are believed to facilitate orthodontic tooth movement. Now, what are the stages of woven bone formation? So basically, in the periosteal area, the bone is converted from the bone is made from the periosteal area to the medullary area, and it has been reached to its maximal thickness in 7 days. Now, what is the clinical significance of this thing? So, if when we have done the when we have initiated the RAP, we have to perform the tooth movement within the 7 days, because during these 7 days the tooth movement will be at their fastest rate. After that, woven bone have been remodeled and the cortical bone have been converted into the laminar bone. Also, medullary bone undergoes resorption. So, at stage of transitory local osteopenia has been developed. Then the release of humoral factor will cause systemic acceleratory phenomena, and the cortical integrity has been reestablished. Now, timeline of RAP starts from the initiation of RAP through the cut, through the corticotomy cuts. Within few days, the reason within 7 days, the woven bone formation have been started. During first couple of months, the RAP is at its peak level, and we have to do our tooth movement, or we have to start our procedures during this month, so that we can get the maximum benefit out of this procedure. During after 6 to 24 months, the RAP have been subsided, and the tooth movement will occur uh, on a very normal rate. Now, what are the indications for our PAOO? So basically, there are four main indications. First one is facilitation of eruption of impacted teeth, resolving crowding and reducing treatment duration, addressing molar intrusion and correction of open bites, and expediting canine retraction after premolar extraction. There are also some contraindications, which are it cannot be used as a substitute for severe posterior crossbite treatment. It is not recommended for cases of bimaxillary protrusion with gummy smile, subcutaneous hematomas and postoperative swellings, and active periodontal diseases or gingival recessions. So basically, periodontal accelerated osteogenic orthodontics is a promising dimension in orthodontic intervention, demonstrating enhanced alveolar bone thickness, reduced treatment duration, and augmented post-treatment stability. It causes minimal post-operative discomfort, contrasting conventional orthodontic experiences. Limited surgical complications, lower root resorptions, and the remarkable reduction in treatment time over a 2-year span attest to the safety and efficiency of PAOO. The technique's holistic benefits, including improved periodontal health, reduced extractions, and enhanced bony support, underscore its transformative potential. PAOO's interdisciplinary nature necessitates comprehensive patient consultation, ensuring informed decision making for optimal treatment outcomes. So, by this, we can conclude that PAOO technique transcends traditional tooth alignment, venturing into the realm of facial aesthetics and serving as a tangible manifestation of in vivo tissue engineering. Although mastery of modified diagnostic and treatment parameters is requisite, once achieved, orthodontists gain access to a potent treatment avenue for their patients. As the adult demographic increasingly embraces orthodontic solutions, especially considering the susceptibility of adults and some non-growing adolescents to periodontal issues, PAOO emerges as an appealing win-win proposition for orthodontists, periodontists, and patients alike. It substantiates the viability of adult orthodontics. It is to be kept in mind that this procedure was introduced in the year 2001, and since then a lot of procedures have been introduced in the field of orthodontics for the fast tooth movement, including laser therapy, and many others. And since Vilcodontics is an invasive procedure, we are moving towards more of a non-invasive procedures, and there has to be there's a great scope for getting some non-invasive procedures. But till then, Wilcodontics is an very good method for the faster tooth movement. These are my references. Thank you so much.